Thank you to Sages for your kind invitation and the honor of the podium. I will be joining my colleagues today in discussing different types of mesh. I'm happy to provide a look into the data and give my perspective regarding the appropriate use of biological mesh. These are my disclosures. Wound complications are a very common result, and mesh infections occur anywhere from 1 to 8% of the time after a ventral hernia repair, as per literature. But unfortunately, we do not know the true number. One of the most common reasons for hernia recurrence is a wound complication, which may then result in another repair and further costs associated with the hernia repair. These are some of the common goals that we as surgeons all have for hernia repair: closing the anterior fascia and therefore avoiding bridging, obtaining a low rate of infection postoperatively, for the patient to have a good quality of life, short hospital stay, decreasing the cost in the operating room and afterwards, and also to have procedures that are reproducible and easily taught to residents and fellows and other surgeons. But hernias come in all different shapes and sizes, and some are more complicated than others at the start. There are also many patient factors, contamination of the operative field, and even patient choices, which may influence us to choose one product versus another. The ventral hernia group guidelines are suggestive, but one should consider that one should consider using biologics as the case gets to become more complex, such as those in grade 3 and grade 4. However, there are no definitive guidelines to influence surgeons what type of mesh to use in each case. These decisions are most often made in the operating room by the surgeon. But when do we actually then decide to use biological meshes? So these are our reconstruction options in complex high-risk patients. We could potentially just obtain skin closure, primary fascial closure with no mesh reinforcement, or repair these cases with a permanent synthetic, an absorbable synthetic, or potentially a biological mesh. When looking into the literature, one should consider studies like this one discussing predictors for synthetic mesh failures and complications. In this study of 3,470 abdominal wall reconstructions, there was approximately a 2% rate of mesh infection. And these predictors of mesh infection were patients who were on steroids or immunosuppressant, cases which were urgent repairs of patients who had a surgical site infection. Predictors of mesh explantation were types of mesh, especially the EPTFE mesh, onlay meshes, and also in cases where there was an anerotomy, which there was an increase of odds ratio of 5.17. As demonstrated in the previous study, anerotomies put mesh at risk of infection. In this study from our institution, we looked at over 4,000 cases and identified those patients who had anerotomies during their ventral hernia repair. Despite the fact that we placed mesh in the preperitoneal and retrorectus plane, and this regardless of the type of bowel involved, an anerotomy was associated with a significantly higher rate of mesh infection and then further hernia recurrence, especially when we follow these patients long term. Certainly, this data has changed our practice. First of all, not all biologic meshes are the same. This is just a table, which is fairly outdated, but a lot of these meshes are still on our shelves. But this table just gives you a few options, and many of these meshes really don't have a lot of data behind them. One of the biggest problems with studies on biological mesh is that usually these meshes are used in the worst and most contaminated cases where no mesh will actually do well. This is a critical appraisal by Mike Rosen 10 years ago, which summarizes some of the issues with biologic mesh at that time, which include a high recurrence rate and also a high cost associated with biologic mesh use. 3 years later, Dr. Rosen published this, which was their experience with using biologic meshes. These cases, about 6% were bridging, 37 patients had an anterior component separation, and as you can see, the recurrence rate was about 31% in a very complicated group of patients. Looking further into the literature, Dr. Itani looked at 8 different studies, a total of 635 patients, of which had alloderm surgices and stratus placed, and these were mostly contaminated cases. They had a 21% recurrence rate with a 26-month follow-up. Yet another study, and this one from Dr. Nahabedian, Sosin, and Beno, is looking is only 2 years old and reviews many studies which have used biologic meshes. The conclusions that the authors found were that biologic meshes are beneficial in contaminated cases. There is less explantation with biologic meshes than with synthetics, and that there is no increase in 30-day surgical site infection. Our group also looked at over 200 of our very own biologic mesh cases done at our hernia center. These were performed with many different meshes that we have in our hospital, and what we found is that stratus had the lowest recurrence rate when compared to the rest of the meshes. This is a study by Dr. Butler and Garvey, which shows probably the best long-term outcomes in complex cases using biological mesh. In fact, when excluding bridging mesh, recurrence rate was 8% at 5 years. Very few synthetics even have this kind of data at this time. This is our group using Stratus Mesh, 281 patients. You can see that the mean defect size is almost 300 centimeters squared. 85% of these are contaminated cases. About 20% of them actually had fistulas, and 37% were had an infected mesh. Many of these patients had a component separation, delayed primary closure. Wound complications were high, but the recurrence rate with a 17-month follow-up was only about 10%. And when excluding those patients who actually had bridging meshes placed, there was only about 6.6%, which lines up very nicely with Dr. Butler's data from MD Anderson. So here's an example of a high-risk patient who I, in my practice, would likely use a biological mesh. You can see here that she has a peristomal defect, and she also has a sizable ventral hernia defect of over 10 centimeters in the midline. The patient lost some weight preoperatively, and this is her intraoperative photograph. I have done a pre-peritoneal repair on her, completely taking down the peritoneum, not doing any type of a component separation, and including her stomal defect as well as her ventral hernia width of the defect. This was about a 15-centimeter defect. However, with her good weight loss preoperatively, the fascia could be approximated without any type of a component separation. Okay. As this was a contaminated case, we went ahead and used the biological mesh. I think it's very important that these meshes are secured laterally, that we place sutures and then medialize the fascia towards the midline before actually using a suture passer to bring these sutures through the abdominal wall. This allows for the mesh to be nice and taut and not too does not wrinkle in the midline after the sutures are tied. This is a picture of the patient's fascia completely closed, and then also a incisional wound vac to help prevent wound infections. And this is a post-operative photo after the patient has had her hernia repaired, as well as had her stoma taken down in one same procedure. Now, considering single-stage versus two-stage operation, here's also our group's data taking care of patients with wounds which are CDC class 2, 3, and 4, almost 300 patients. You can see that the wound complication rate is fairly high, but the hernia recurrence rate in these single-stage operations is only 7%. And the recurrence rate, as usual, has been associated with wound complications. Further data from our infected mesh cohort of patients shows that primary repair of complicated ventral hernias results in a very high, almost 90% recurrence rate, while reconstruction with a biological mesh has less than a 10% recurrence rate. And when considering long-term value and cost effectiveness, one should consider the OR charge data for a case using biological mesh versus a primary closure, and then add the cost of the 90% recurrence and a subsequent operation. Now, this clearly demonstrates an OR saving if biologics are used during these cases at the initial operation. But most importantly, it is a demonstration that saving the patient from the disability of having subsequent surgery and recurrence, and what this cost is to the quality of life of each patient. So in conclusion, I think that biologics can be cost effective on many different levels, and we need to do our best to identify those who may benefit from biologics, optimize those patients when making, when making product choices. We need to use the ones that have long-term data, which shows good results. Thank you.